Good practice of supplementary immunization against measles outbreak.
The latest outbreak of measles in Mongolia took place in 2001, and the last case of measles was reported in 2010. The National Surveillance and Information System data indicates that the coverage of vaccination against measles was consistently high above 95% since 2000. However, in March 2015, the first case of a measles outbreak was reported in Bainzurg district, Ulaanbaatar city. Thus, Mongolia faced the outbreak caused by an imported virus, which spread to the capital city and other provinces. The situation started complicating the disease control and elimination activities. The UNICEF worked closely with the Government of Mongolia, Ministry of Health and Sports, National Center for Communicable Diseases and World Health Organization in response to the outbreak.
Mongolia was declared measles-free in 2014. However, in March 2015, the country experienced an important measles outbreak, a serious situation for Mongolian children. Following the outbreak, the government of Mongolia requested UNICEF support to provide technical and financial assistance to conduct a supplementary immunization activity for 372,000 children aged 6 months until 6 years old. With the support of our headquarters and regional office, UNICEF Mongolia provided immediate assistance to the government to respond to the outbreak, in particular in 4 areas of intervention. The first area was donation and procurement of 372,000 doses of measles vaccine and required immunization devices. We provided vitamin A for all children aged between 6 and 72 months of age. Secondly, technical assistance on microplanning of supplementary immunization activity. In order to undertake this activity successfully, we recruited an international consultant on microplanning who trained 95 national EPI managers, who later supported a cascade local training for 1,195 health workers to conduct the supplementary immunization activity nationwide. This is a massive country, so it was very important to ensure that this trainer could reach all corners of Mongolia. The third area of intervention was communication. Very important. This is a hyper-connected country with a young population. The way we communicate is instrumental to the success of the campaign. In order to do so, UNICEF promoted the use of communication channels such as TV, radio, but also poster, leaflets, but also massive use of social media, Facebook and Twitter. As a result, the supplementary immunization activity messages reached 1,250,000 people across the country. Finally, we supported rapid coverage assessment and also the methodology development and its training. And UNICEF conducted RCA in 12 provinces and districts across Mongolia. For the success of the campaign, leadership of the government was instrumental, and we worked very closely with the Ministry of Health and our partners at the government.
Good practice of supplementary immunization against measles outbreak.
In March 2015, a measles case was reported in Bainzurg district of the capital city, which was the beginning of the outbreak that covered 21 AMACs and 9 districts of the capital city. So at the end of the year, number of confirmed cases of measles reached 23,464. The age of affected people by this disease ranged 1 month to 59 years. The rate of morbidity was highest in the age of groups of 2 to 9 months and 15 to 28 years. By April 2015, 44.8% out of total confirmed cases were children aged 2 to 9 months. According to the World Health Organization, the reason for the disease to escalate into outbreak was the accumulated number of children left out from routine vaccination from year to year.
Every year, a number of children are left out in the routine measles vaccination. As the coverage is not 100%, but 95, 97, or 98%, it means 5% are left out, and the next year the number swells by 2% and so on. At the end, it leads to quite a number of people who are not immunized against measles. When this number exceeds the epidemic threshold, it leads to the outbreak.
The circumstances required immediate response against the measles outbreak. Accordingly, the Ministry of Health and Sports issued an order number 188 to promptly prepare for supplementary immunization against measles outbreak. The supplementary immunization of measles was launched to vaccinate, first of all, children aged 6 months up to 6 years. The launch ceremony of the supplementary immunization was organized on 15th of May 2015 at the Health Center of Weinzurch District capital city. In parallel, each AMAG launched the campaign and worked to raise awareness among public. These are the good practices created or introduced during the organization of the supplementary immunization nationwide.
Good practice 1. Uniform understanding and coordinated response.
It is crucially important for doctors and health workers to share the same understanding and coordinate organizational arrangements during any outbreak or epidemic. For this reason, the National Center for Communicable Diseases has revised the Guide on Supplementary Immunization Against Measles Outbreak, printed in 2012 by the Immunization Department of the National Center for Communicable Diseases. This guide covers date of supplementary immunization activity, target age to be immunized, establishment of additional temporary vaccination posts, dispatching of mobile immunization team, development of microplans and mapping, cold chain management, flow of work at the temporary vaccination posts, finger marking, safe injection methodology, supportive supervision, methodology to carry out rapid coverage assessment including forms to collect vaccination data. The Guide on Supplementary Immunization for Doctors and Health Workers discusses in detail all relevant concepts starting from ways to organize preparatory works through monitoring and evaluation.
We prepared the guide in 3 months. What did we include into its contents? First, we identified the target group of the supplementary immunization campaign. It depends on the age group that should be vaccinated. In general, when we vaccinate young children through supplementary immunization, we usually use permanent vaccination posts. Because children from 6 months up to 6 years of age are usually those who attended kindergartens. Therefore, we divide them into children attending kindergartens and children staying at home. Then we further divide them. The guide clearly indicates what group of people to be covered by supplementary immunization. One special feature added in this guide is measles vaccination of 6 months old children, something we have never done before. Because we are covering 6-month-old children, the guide includes detailed warnings to parents of such children.
This guide and posters demonstrating how to effectively organize supplementary immunization against measles outbreak and ensure improved coverage on all levels were disseminated to all IMAG, SOM and district health complexes and family health centers. So with the help of the Guide on Supplementary Immunization Against Measles, all doctors and health workers had a uniform understanding and information that enabled them to respond to outbreak immediately and organize the campaign of supplementary vaccination successfully.
The guide gives detailed information on the vaccine. It is a very important book. We worked mainly according to this book. Our plan was also developed according to the book. The microplans were based on the samples given here. We read and studied. We attended trainings on this guide and were able to successfully vaccinate.
Good practice 2. Microplanning and mapping.
Since 2003, World Health Organization has appealed to its member states to implement Reach Every District strategy, the strategy to reach every district. Mongolia has adapted this strategy under the title Strategy to Reach Every Som, District, Horo and Bag for the full immunization coverage of each child in 2008. Obstacles faced in increasing the immunization coverage have been identified within the framework of this strategy, and micro-planning was done to address those obstacles. The micro-planning aims at improving the outreach and coverage of immunization services for children who missed vaccination, unregistered citizens, people living in remote areas, mobile or vulnerable groups.
Good practice of supplementary immunization against measles outbreak.
UNICEF, World Health Organization, and National Center for Communicable Diseases jointly organized a training on micro-planning for supplementary immunization for national and local trainers comprising for 95 doctors and specialized inspectors in first week of May 2015. Abe Abeida, immunization specialist from East Asia and Pacific region, taught on micro-planning for supplementary immunization during the training. With the support of UNICEF, the trainers have successfully provided technical assistance for preparatory works of supplementary immunization against measles in 21 AMACs and 9 districts in the second week of May 2015.
All three of us attended the training on measles immunization. By attending the training, we developed the microplan. Then we worked according to our microplan. So we planned in total to vaccinate 184 children, and so far we vaccinated 174.
UNICEF organized in its targeted AMAC Hoof School the training on microplanning for supplementary immunization, including heads and vaccinated nurses of 23 SOMs and 5 family health centers.
In general, in any work, when planning is done well and things are carried out according to the plan, the performance and quality are quite high. For this reason, we prepared national trainers to learn how to do microplanning and how to work. So these trainers worked in 21 IMACs and 9 districts together with the local immunization specialists to organize further trainings for all SOM doctors to teach how to microplanning. So accordingly, all primary level facilities in all IMACs and districts have done their own microplanning.
Doctors and health workers worked according to the following outline when developing their microplans. Development of the integrated plan, development of immunization team transfer schedule, work schedule of temporary vaccination posts, schedule for work of mobile immunization teams, schedule of work of fixed vaccination posts, sample for human resources allocation of AMAC, SOM, district and family health centers for vaccination against measles, list of people to work from kindergartens at temporary vaccination posts against measles immunization of AMAC, district, SOM, and family health centers. Schedule of supportive supervision for temporary, fixed, and mobile vaccination posts. Survey of children with disabilities to cover with immunization against measles. We identified catchment area of immunization posts and mapped their location in order to identify activities for each level. Our Family Health Center, Emerton, organized supplementary immunization against measles by developing a microplan, conducting a survey of children aged 6 to 59 months, mapping and carry out the planned immunization activities. In the microplan, we included what is to be done as preparatory works, what is to be done in terms of organizational arrangements, listing activities such as issuing order of the head of Family Health Center, organizing training for doctors and staff, coming up with checklists of necessary items for immunization work, and how to organize media campaign and etc. We came up with 1,171 children of 6 to 72 months of age to immunize in our microplan, and so far immunized 1,055 children, exactly according to our plan, which is 91%. Marking location of vaccination posts and targeted children help to identify the location of difficult-to-reach children who have missed immunization, list the names of children with high risk to miss immunization with the location and number. This helps to extend the coverage of immunization to migrant population and children who are not registered or homeless. Thus, IMAG and district microplan mapping identified 371,971 children to immunize age 6 months up to 6 years nationwide.
Good practice 3. Outreach services.
Over 500 fixed posts, over 450 temporary posts, and 782 mobile teams were mobilized during the supplementary immunization against measles outbreak. Over 3,850 family doctors, vaccinated nurses, managers, specialized doctors, school and kindergarten doctors worked during the campaign. Also, over 600 drivers participated in the immunization campaign and rode in total over 237,400 kilometers of road to reach households living in remote areas. There are many SOMs and Hufskal IMAG located in remote areas. In order to reach every child with immunization, several teams were dispatched to reach remote bags.
The supplementary vaccination against measles was organized in our IMAG by outreach to remote rural bags. In total, we had 3 teams consisting of 15 people. 1 fixed 2 mobile teams were sent to the field. In doing so, we rode in total 1,320 kilometers and covered 703 children in all. Out of 703 children, 633 who have their registration in our IMAG have been vaccinated. The remaining 70 are not registered in our records. They are mobile population. The remotest bug in our outreach was After-Ir. We had traveled 270 kilometers in order to do our supplementary vaccination program.
Out of 371,971 children to be immunized against measles nationwide, 347,685 were immunized, and the coverage was 93.5%. Each child immunized against measles was marked on the pinkies to confirm the vaccination status.
Well, I am. We are vaccinating with our elderly mother, so I've been worried about my son's vaccination. However, they came here and vaccinated him. It's good. Things have become so good nowadays.
Nationwide during the immunization, 3,190 children were postponed due to illness, 189 were not at home, 1,760 moved to other places, and 6,363 children missed due to various reasons.
Good practice 4. Information, education, communication on supplementary immunization.
UNICEF was in charge of information, education, communication of supplementary immunization campaign and provided technical and financial assistance. Information, education, communication was carried out together with the Health Development Center and National Center for Communicable Diseases. 100,000 leaflets and 2 types of posters, 3,000 pieces of supplementary immunization were printed and disseminated. They were displayed in all 512 family and SOM health centers and outside kindergartens throughout 10 days of supplementary immunization campaign. Also, 1-minute ads on benefit of measles vaccine, information on immunization, immunization day and location were broadcasted to the public through television and radio stations. In total, information ads were broadcasted 210 times through Mongolia National Public Radio, FM 101.7, FM 95.1, FM 104, whereas ads were broadcasted 68 times through Mongolia National Public Television, UBS, TV5 and TV9 television stations. Benefits of immunization were broadcasted to public through 4 programs, 20 to 50 minutes long, by Mongolia National Public Television, Eagle, MN25 and UBS. Besides this, each AMAG advertises supplementary immunization against measles through the local television. At the end of the supplementary immunization campaign, 190 volunteers were mobilized during the weekend of the 23rd to 24th of May 2015 in 95 horrors of 9 districts of the capital city in order to increase the coverage, inform the public on immunization, and identify people who have not been reached in order to vaccinate children who have not been late in getting the vaccines.
Our targeted group was children aged 6 months up to 6 years. However, we cannot communicate effectively with them. So our advertisement campaign was aimed at the parents and caregivers who should bring them for vaccination.
Good practice 5. Supportive supervision during supplementary immunization.
National Center for Communicable Diseases doctors and health workers have worked together with district doctors and health workers in charge of immunization by providing supportive supervision and district professionals exchanging the experience. Supportive supervision was provided on supplementary immunization activities according to checklists in 9 districts of capital city, Arhangay, Dornod, Zahong, Hovd and 2 AMAGs. Providing supportive supervision for immunization activities is an important process aimed at promoting collaboration to improve quality of immunization services, to identify and to solve problems and bottlenecks encountered in course of the services. The supportive supervision was carried out according to checklists containing specifically designed questionnaires. The findings were analyzed and recommendations were given on measures to take. The process of implementation of the campaign was continuously monitored.
The National Center for Communicable Diseases, AMAG and the district health centers, together with district specialized inspection offices, have carried out supportive supervision in connection with the supplementary immunization against measles in 3 phases. The first round of supervision inspected the preparatory works for the immunization campaign. The midterm or process supervision coincided with administration of vaccines. During this round, the supervision was carried out on the way vaccines were prepared and administered to children. The final round of supportive supervision inspected whether the immunization campaign was carried out according to the plan. In all these supportive supervision sessions, our Achlal Nalach Family Health Center received good ratings.
The supportive supervision involved not only health organizations, but also a specialized inspection agency.
In our Hovd AMAG, we carry out supportive supervision altogether, including health department, specialized inspection office, SOM and district family health centers wherever it is needed. All organizations work together because we share the common goal. In general, the remotest SOM in our AMAG is located at 400 kilometers from the AMAG center. Then there are SOMs located at 100, 150, 160 kilometers in rocky mountainous terrain. So there are risks to undermine the vaccination regime. Therefore, we aim at inspecting to that level.
Good practice 6. Rapid coverage assessment.
Rapid coverage assessment is the most suitable way to identify children who miss vaccination and to monitor them. Places where children might miss immunization are peripheral horrors of capital city, remote SOMs and BAGs, gold mines, herders on the move for their livestock grazing, and migrating population. These places were targeted for rapid assessment of the immunization coverage.
Well, how many children do you have?
3 children,
How old are they?
5 years old, 3 years old, and 1 year old.
So did they get measles vaccines?
Yes, they did.
Can I see your children?
We randomly selected at least 20 children in each bag to verify whether the children got vaccinated. If you find a child who is not vaccinated in this process, we clarify from parents the reasons and note down the survey questionnaires. The assessment team carried with them vaccines and other supplies so that whenever they found unimmunized children, they vaccinated on the spot.
Good practice of supplementary immunization against measles outbreak.
The rapid coverage assessment on the immunization coverage was carried out in Баян-Улгийн, Баян-Хонгор, Говьолтой, Дархан-Уул, Хөвсгөл, Дундгов, Ovsamax, and 9 districts of Lambata City in order to expedite the immunization process. The rapid assessment was carried out in selected IMAX and 10 buildings, 3 kindergartens, 98 streets of 34 horos of 9 districts of the capital city. During this time, 2 to 3 unimmunized children were found in each of Sukhbata, Bayangol, and Hangul districts of the capital city. Therefore, 10 more children were selected from those districts to check as specified in rapid assessment methodology, and they were all found to be fully immunized. This shows that the supplementary immunization coverage was relatively high.
Today I carried out the rapid assessment and just visited the 20th household to finish my work. The rapid assessment is done to monitor the vaccination activities, the current immunization against measles for children. 20 households are selected from each district. All of them were visited to inspect the immunization coverage. If an unimmunized child is discovered in this district, then additional 10 households were selected for visit. In Nalak district, the plan was to vaccinate 4,781 children during supplementary immunization campaign, and the coverage is 95%. Today, when rapid assessment was carried out in 20 households, we didn't find a single child who was not vaccinated, so the immunization work was done at high quality level.
Lessons and consideration for future. Prompt organization of supplementary immunization against measles, together with the provision of A vitamins to children between 6 months up to 6 years of age, in total 372,000 children, was important to tackle in the outbreak of diseases among young children. The coverage reached 93.5%, and supplementary immunization conducted among unimmunized children through family and some health centers has reduced the risk of morbidity and mortality among young children. But there are certain lessons and things to consider for future.
There were many things we learned from this immunization campaign. For example, the need to improve social mobilization, information, education, communication, and to provide health education. Another thing we learned is to do planning well and through macro planning, reach difficult-to-reach populations. Communicable diseases are global problems which respect no borders, so preparedness is very important. We had faced a shortage of measles vaccines and vitamin A supplies. It is another issue to keep in mind.
Micro-planning and information education communication need to be planned at least 3 to 6 months in advance in future supplementary immunization campaigns. This is allow local health organizations to plan their works ahead of time and carry them out with sufficient notice. Also, this is allowed to increase participation of other sectors and mobilize the public and the support.
Workload has been very high in health sector, especially at primary health facilities. It seemed like public perceived this work only as a job of a health sector, in my opinion. If there was no such notion and schools and kindergartens collaborated more, if we mobilized them more, we could have reduced this high workload. The health sector budget items are predefined. There is no such cost item in the budget which would say this money could be spent on supplementary immunization (IEC) or producing leaflets for public awareness and education. No cost items exist for paper, cartridge, and other expenses needed in such campaigns. Also, there is no cost items in the budget for fuel due to mobile immunization outreach. When staff work extra hours on top of their working hours, it is not clear whether they would be compensated later or not. So when the health sector faces such risks, there are significant constraints faced to mobilize contingency funds. Some parents didn't appreciate the significance of vaccination and refused to get their children vaccinated. It became a factor leading to outbreak of measles and this immunization campaign of 10 days. When we evaluated the circumstances, we understood it is very important to keep the routine measles immunization coverage above 95% and for this purpose to conduct targeted catch-up immunization for 4 to 5 years for children who had missed vaccination.
In response to outbreak of communicable diseases, which claim children's lives in large numbers, it is vital to ensure stock of necessary vitamins, drugs, vaccines at the national level.
And we are committed to undertake with our partner a process of lessons learned for this not to happen again in the past. But the first lesson that is important to learn is we need to have, at government level, a long-term policy to prevent communicable diseases based on survey and coverage data. But also something that we learn is the crucial importance of preparedness. And we need to ensure that preparedness is embedded in disaster and outbreak response and preparedness plans, well prepared in advance. But also, whenever we are preparing for a supplementary immunization activity, start in advance with its preparation. This is a detailed, complex activity that requires 3 to 6 months anticipation time for us to capture the target population and to reach the highest possible target. We also work very closely with WHO, our close partner at the UNCT and international UN level. Now, this collaboration was very important to ensure that together we can join maximum efforts. But also, I would like to take this opportunity to acknowledge the importance and the great contribution of the Measles and Rubella Initiative for the continued support to tackle this outbreak in Mongolia, and also to improve child survival, saving children's lives. The Measles and Rubella Initiative has helped and contributed generously to Mongolia by providing financial support to undertake supplementary immunization activities, but also to continue what was already a tradition of support, as the Measles and Rubella Initiative had already supported Mongolia in 2007 and 2012. This support was crucial, not only to save life, but also to ensure that we strengthen the system to avoid continued and repeated outbreaks of measles. There are a lot of lessons to learn. There is a lot of work to improve. The system are ready and prepared to address measles. And we avoid any state of complacency vis-à-vis measles threats and outbreaks. We are looking forward to continuing to working together with all our partners and with the Measles and Rubella Initiative to ensure that Mongolia can be stronger and readier to prevent measles outbreak, and to ensure that Mongolia can go back again to its status of a measles-free country.
In order to ensure success for future work, it is important to assess and learn from whatever was done previously. In 2015, the health sector was able to organize a rapid response to measles outbreak through intensive work according to the plan, which allowed the successful coverage of targeted groups with supplementary immunization, and the measles prevention had protected health of thousands of Mongolian children.